Now, our next speaker is Professor Claire Harrison, who, I don't know where you are, Claire, there, who is going to talk about MPNs and young people. Welcome, Claire.
Michelle, I just want to say thank you so much. That was amazing. It's such a lovely event, this, where the community gets together, family, patients, clinicians. It's absolutely fantastic. We have got 100 or so people listening online, so we're not forgetting you, and we're joining you as well. We have had to change the agenda a little bit today, and I'm actually presenting on behalf of Professor Kalajan, who would be here. But unfortunately there's some family illness, and I'm going to talk about some work we've done about what has happened to young people who've been diagnosed with an MPN. And part of the rationale for that is because although in the minds of many people, these are conditions that are described as having a median age at diagnosis of 65 or 68, median means average, right? So there are still many folk who are diagnosed much earlier and also much later, and these are things that we need to think about. Every person is an individual, they're not an average. So we decided to look across a group of colleagues, which I'll describe to you in a minute, at what happened to patients who were diagnosed less than 25 years old. Understanding that this was a relatively rarer group, understanding because we'd already looked at what was published in the medical literature, and we all often will publish something that's amazingly good, or, oh, this was really bad and we want to share the message. We don't, there's a lot of grey in the middle that we don't share. So we wanted to collect this, and we collected this information across a group called the European Haematology Association. There is a British, a European, an international, and an American Haematology Association, and that there's a whole group of individuals who share experiences around MPN. This is a group that's chaired by Professor Kalajan from Paris and myself. And we worked with Jean-Christophe Iannotto, who came to Guy's for a 6-month sabbatical to collate all of this information across many, many countries in Europe, and also Taiwan, because there's a Taiwanese doctor who's very enthusiastic and part of the European group. We collected data on 444 patients from 40 different clinicians and 14 different countries. And we decided to collect patients who had been diagnosed following the most recent diagnostic criteria. So one of the problems when we look at this data, as I'm going to share it with you now, and then talk about what we think we would like to do going forward, and it would be good to hear your opinion as well, is we can only take a snapshot in time, and ultimately, if we take a snapshot of everyone who is diagnosed age 25 or less, we will be following patients for many, many years, and our treatment plans and ideas and understandings have changed over that time. So these are the 444 patients, and you can see that most patients were diagnosed between the ages of 20 and 25, so that's just over half, and very few were diagnosed age under 10. Most had ET. After that, the next most common was polycythemia vera, and then there were a group of patients with other conditions. So just to share with you then what happened to these patients, how did they present? What we found was, according to the data that we collected, that symptoms and symptoms that we would recognise as being part of disease were quite common. So about almost 40% of these patients reported symptoms, and it's very hard to go back over 20 years in medical records and pick these things out, so there were probably more. And often these were what we would call hyperviscosity, so thicker blood-related symptoms, so headaches, fuzzy-headedness. But we also found that fatigue, an enlarged spleen, itching, and other symptoms were very common. At the time of diagnosis, just over 10% had had a blood clot, and about 10% were diagnosed in pregnancy, because we usually do a blood count on women when they come and they're pregnant. I can see people standing at the back. Do you want to come and sit? I just think it's a long time to be standing. And maybe people, if they've got a space next to them and they're on the end of the row, could, if you see somebody coming, just shuffle along. Other things at diagnosis, so this is divided according to the disease group. So this is ET patients. You can see their platelet count, as we would expect, was high. These are the PV patients. Interestingly, quite a higher proportion female, which we don't see so often in older patients. PV patients often had hyperviscosity, so thick blood symptoms, which we'd expect. Quite a few had an enlarged spleen, were complaining of fatigue, and often had itching. We were interested to look at mutations, so Donal mentioned mutations in his presentation, and the pattern here is much as we might expect. So the PV patients, most of them had JAK2, and when we look back at the medical literature, we found that many didn't, but in this more recent cohort, they did. The pattern for mutations for ET patients was quite different though. So this blue segment here is actually triple negative, so lacking a mutation. So this is something that is more common in younger patients than in older patients, and I'll show you that in a bit more detail on the next slide. This pattern for patients who had mainly a type of myelofibrosis or an unclassified MPN was as we would pretty much expect. This shows you this pattern of mutations in ET patients according to age, and you can see a very striking finding here that in this group of patients from these centres, from 40 different doctors, all of the ET patients who presented aged less than 10 were triple negative. So we are trying to understand more about the biology of that, and there are people in this room, Rebecca Fruin, Alessia Khan, and others who are looking at that on behalf of the MPN community. So what I'm sure you all want to know is what actually happened to these patients. So on average, the follow-up was 10 years, but some of these patients had been followed up for almost 50 years. And 40% of them had follow-up of more than 10 years. 3/4 had an antithrombotic, so an antiplatelet drug or an anticoagulant. Many of the PV patients were having phlebotomies. And then concerning a drug treatment, so the first finding was surprising for us, given that we generally give a drug to lower the blood count to patients who are broadly based on age, and then whether they've had a blood clot. To find that 2/3 of these young people were being given a treatment was a surprise. So perhaps more than we would expect given international recommendations, and perhaps more than we would have expected being given hydroxyurea or hydroxycarbamide, because interferon here in orange or anagrelide here in purple would be the drugs we might expect nowadays to offer younger people. So it's probably because of this kind of historical dragging forward of the data from the past and the practice from the past. And what you can see on this slide is what was given to ET patients and what was given to PV patients. So the PV patients got a little bit more interferon, and as anagrelide particularly affects the platelet count, many more ET patients got anagrelide. So what happened in terms of new blood clots? Remember that about 10% of these patients had had a blood clot at the time of or just before diagnosis, and about another 11.5 to 12% had a subsequent blood clot. About a third of those 10% who presented with a blood clot at the beginning had another one. So we know that's a risk factor for an event. So that kind of validates our thinking about if you've already had a blood clot, we really should be doing our best to stop that happening. Bleeding of various types could be minor, a big bruise, some bleeding after going to the dentist, occurred in about 1 in 10. But we would say this is perhaps a bit higher than we would expect to see given a younger patient population. Excuse me. Where were these clotting events? So in younger people, generally, they don't have high blood pressure, they don't usually get age-related diabetes, etc. So we didn't see so many heart attacks or strokes as we might expect to see in an older population. But we did see quite a lot of blood clots in the so-called splanchnic veins, so in the tummy area, affecting, for example, the bowel or the liver. And we also have an expert, Malika Secker, in the room today from the Royal Free Hospital who's been working on that. So these are particularly common in MPN patients, but seem to be especially common in younger people, and we were surprised about that. A question we often get asked, does it matter what mutation I have? This is hopping back a little bit to Donald's talk, and risk of event. And what we found for ET patients was that JAK2 positive ET patients were more likely to have a blood clot than patients who had a CALR mutation or were triple negative. There were very few ET patients with a mutation in the third gene, MPL. So in current treatment, we would definitely be offering JAK2 positive patients aspirin. Many of us would offer CALR positive patients aspirin, but we would be a little bit more relaxed about that. But we definitely want to know our JAK2 patients are taking it, which is in line with this data. Bleeding wasn't really different according to the different mutations, but it happened more often if patients had already had bleeding and they had a very high platelet count, so more than 1,500. Again, in common with Donald's talk, and something that I know many patients are concerned about, was what about transformation? The disease changing from one form into another. So there were 10% of these events over this quite long time of follow-up for many of the patients. But what I want to draw your attention to was that many of these were actually ET patients, for example, changing into PV, which we sometimes see over time, perhaps as the JAK allele burden goes up, etc. There were some cases of myelofibrosis, but there were very few, only 3 out of 444 patients with a follow-up of over 10 years developed leukemia. Overall, most patients were still alive, and in terms of causes of death, these were not all related to their blood condition. And the mean survival was at least 30 years. That sounds great, but it's not great if you're 20. So this is something we are going to work on, and we will pull out in particular the younger patients, and we will keep following this up. I think this, to me, given this is a group of patients who were treated according to older recommendations, not so intensively, perhaps a little bit more drug therapy than we would like, perhaps a bit more hydroxycarbamide than we might normally give. I think this is good, and I think this is reassuring, but maybe we can have a discussion about that in the panel discussion. Another thing that we thought about including on the agenda today was maternity, and there is just some data here. So actually, this is completely in line with what we expect. Around 80% of successful pregnancies, and by the way, that's pretty much what would be expected in the general population. Okay, and Michelle, I heard you talking about that as well. Yeah. So just in conclusion, young patients were not so rare, are mainly diagnosed with ET. The mutational landscape is not generally different, but there's this thing about very young patients lacking mutations. We seem to be giving more drugs than we might have expected. And I've shown you some data about blood clotting, etc. But I want to just point out that these are medical experiences. They are not the whole experience. So maybe some of the things we should be thinking about as a blood cancer or as an MPN community is how do we collect more the lived experiences? And Alice is going to come and talk to that shortly. So what is our plan now? What have we done? We've published these results. We've spoken about them at conferences. We spoke about them yesterday at the Doctor's Day, and we're speaking to them today and sharing them with you. We are planning as a European group, which is heavily represented by doctors from the UK as well, to pull together some international guidelines for diagnosis and management of young people with MPN, and we hope to work with patients to do that, patients from MPN Voice and other European groups. And we hope to form a supportive network of young people with MPN, and there's more to follow about this and to learn about the whole experience. So hopefully you found that interesting, and I look forward to discussing that with you later. Thank you.
Thank you, Claire.